We'll talk about vitamin K antagonists and this class of drugs called the direct thrombin inhibitors. Okay, we're going to leave the other drug classes, which all kind of fall into this anticoagulation, antiplatelet um, pathway for other cases. And so we've already kind of discussed, like aspirin as being an antiplatelet type drug. We touched on the glycoprotein 2B3A inhibitors in the MI case, and we'll come back to these throughout the curriculum. And then we have yet to talk about the last two shown here. We'll talk about those another day. So let's talk about the first class of drugs called thrombin inhibitors. And so remember, thrombin was factor 2A. And so these drugs can be further subdivided into your heparin molecules, which are basically both direct and indirect thrombin inhibitors. And you'll see why in a minute, as well as your kind of traditional direct thrombin inhibitors, warfarin, the rudins, and the gatrabans. And so, obviously we said thrombin was going to be a key, essential player in a lot of these coagulation cascade targets, and you're going to see how that is mechanistically, piece by piece. Okay, and so the thrombin inhibitors, we said they could be the indirect inhibitors of thrombin, and this can even further be subdivided when you look at the heparin. So probably the oldest molecule in this category are the unfractionated heparin molecules. And so this is a conglomeration or a mixture of a whole bunch of molecules that are heparin, and they're polysaccharide in nature. The second kind of generation of indirect inhibitors of thrombin include what's called the low molecular weight heparins. Okay, and so enoxaparin, deltaparin, and some of the other ones that are coming through the pipeline. These are kind of your second generation heparin molecules. Mechanistically, they work very similar. We'll show you some comparison and contrast between these two. And then the other groups of drugs are your direct inhibitors of thrombin, which are listed there. Okay, so remember we said thrombin stimulates a whole bunch of physiologic targets. Thrombin plays major roles in neutrophil adhesion, monocyte activation and infiltration, the secretion of platelet-derived growth factor from both immune cells and from endothelial cells, which has a direct effect on smooth muscle. Thrombin can stimulate or influence lymphocyte activation and migration, and it directly enhances endothelium activation, which produces a whole host of proteins and molecules that have biological consequences. Nitric oxide, prostaglandins, tissue plasminogen activator are just three that are listed here. Thrombin has direct stimulatory effects on platelet adherence and aggregation. Once these platelets become activated and aggregated, they release thromboxane, which has specific roles in endothelial cell matrix remodeling. And then thrombin can also influence positively fibrin, which basically forms this mesh-like network that makes these clots so sticky. So thrombin is definitely, from a physiologic perspective, an important mediator of coagulation. Likewise, once thrombin, which remember we said was factor 2, once thrombin is activated via factor 10A, thrombin can also influence other coagulation factors. It can activate them. So this is outside of this slide as well. So heparin is actually a naturally occurring anticoagulant. It's made by a whole host of immune cells, basophils and mast cells specifically. And we can use heparin for the prevention and the treatment of thromboses and embolisms, and also maintain the patency, meaning the openness of IV catheters. Okay, and so whenever a patient is given an IV, at some point, depending on how strong or brittle their veins are, you may need to put a little bit of heparin in the IV bag just to keep that vein nicely open. Okay, we use heparin in post-MI during myocardial infarct. We can also use it during the acute management of these patients that are experiencing unstable angina. And so you'll give them a little bit of heparin because you know that basically during the management of these patients, they're going to undergo PCI, balloon angioplasty, and get that clot taken out. We get heparin molecules from the slaughterhouse, typically from either pig or cow mucosa, and these cell suspensions are filtered, and essentially what we do is we clean them up and purify them and sterilize them, of course, and we can give them to patients. And so one of the main things is that in order for heparin to work in our bodies, the endogenous antithrombin molecules that are that we make has to be present. And so if the patient, for whatever reason, is deficient in the antithrombin molecules, this heparin is not going to work for them at all. And you'll see why that's important in a slide or two. Heparins are administered IV. Sometimes we conjugate them to a salt to make them a little bit more stable. And they can be injected into the vein. They are not orally administered. Okay. And so there's two preparations. There's this unfractionated heparin. Okay, and so it's got high molecular weight. If any of you have ever worked in the lab or have done protein chemistry, you know that you can separate proteins based on molecular weight. And so the heavier, bulkier molecules can be fractionated off, but in this case they're not. And so we collect that kind of like that pre-fraction before they're spun down. And so that's the unfractionated high molecular weight heparins. And so these drugs, although they work, they have a relatively narrow therapeutic index, but they've just been used historically for so long, and we know how to use them, that they're still relatively popular. Okay, and so this kind of led into the second generation, these low molecular weight heparin molecules, which are listed here. And these drugs are kind of like new and improved versions of heparin. They have essentially equal efficacy in terms of patient outcomes and so forth. They have increased bioavailability, all right? And again, these are also given IV. And they have less frequent dosing and less frequent monitoring as well. And so for that reason, these are kind of a little bit, quote unquote, better drugs. We'll talk about the differences more in a little bit. Okay, so how do they work? So mechanistically, heparin actually acts like a catalyst, okay, in reactions that involve antithrombin binding to either thrombin or factor 10A, okay? Now remember, this antithrombin is the endogenous molecule that's the inhibitor of the coagulation cascade, and it's made in the liver, okay? And it's a glycoprotein that actually inactivates this cascade. So all this protein does is essentially take the antithrombin, or the inhibitor of the coagulation cascade, with the activator of the coagulation cascade, and just binds them together faster. So that's why we call it almost like an enzymatic catalyst. Okay, and so it makes the antithrombin molecule have a little bit more affinity for the endogenous clotting factors that already exist, brings them together, and when these two factors or proteins are brought together, the clotting cascade is inhibited. And so this is what this looks like mechanistically. So this is the unfractionated heparin. It's quite a large molecule. Okay, and then here is the patient's own endogenous protein. So here's the patient's endogenous antithrombin, and here's the patient's endogenous factor 10A, and here's the patient's endogenous thrombin, also known as factor 2A. And so all this molecule does is it kind of wraps itself around these two proteins, okay, and basically facilitates their binding. Okay, so these two endogenous proteins, factor 10A and antithrombin, they have affinity for each other. They will find each other and bind and become inactivated. But all thrombin does essentially is basically increase the likelihood that these two proteins will find each other and then basically lowers the energy threshold for the binding to occur. So it kind of increases the affinity. Okay, and so that's really all we're doing, is that we're kind of capitalizing on protein interactions that already exist, and we're just increasing the frequency at which they occur. Okay, and so remember we had said that factor 10 was an important factor. These circles got shifted. Let me move them. Factor 10 was so important because it was really one of the key activating factors to activate thrombin. Okay, so prothrombin here, which is this pink box, factor 2, this is not biologically active. Okay, only when it comes into contact with factor 10A as well as factor 5A and calcium does prothrombin get converted into thrombin. Okay, and so this blue box, this blue thrombin molecule, factor 2A, has the ability to activate these other, we could make another, I don't know, it came off. So this blue box here, this thrombin molecule, has the ability to activate factors 5, 8, and 11. Okay, and that's why inhibiting it with something like heparin is so important. Okay, so of course, you know, in terms of toxicity for these heparin molecules, the main toxicity is going to be too much bleeding, right? So too much heparin means the patient's going to bleed, the coagulation cascade is severely restricted, and so you discontinue the drug. Okay, and now if the overdose is kind of so severe that the bleeding is not stopping, or they're losing too much blood, or they're hemorrhaging, there is an antidote to heparin, and so it's protamine sulfate. And what it does is it's like a scavenger molecule. It just goes through the circulation and looks for excess heparin, okay, and binds to it. And then when protamine sulfate is bound to heparin, basically the heparin molecule is inactive. No matter what concentration is floating around, it's not going to do anything. Okay, the one key kind of major, I would say, adverse effect is this heparin-induced thrombocytopenia, sometimes called HIT, H-I-T. And here the platelet count falls to less than 150,000 platelets per ml, or it's essentially a 50% decrease from the pre-treatment value for that patient. And it occurs in about less than half of 1% of all medical patients that are treated with heparin. The heparin-induced thrombocytopenia more often occurs in women, and it more often occurs in women who have been treated with the unfractionated or the heavyweight heparin molecules. Low molecular weight heparins have a much lower incidence of heparin-induced thrombocytopenia, and actually low molecular weight heparins by themselves have relatively little effect on platelet activity to begin with. Okay. So where do we use heparin? We can use the unfractionated, low molecular weight, and then this other molecule called fondaparinux, which is kind of in this heparin category. We'll talk about that more. To initiate treatment of venous thromboses and pulmonary embolisms, because these drugs work so quickly. Okay. The other time we use heparin is before warfarin, and we'll talk about how important this concept is. Is that you'll never start warfarin, which is oral. It's an oral tablet or Coumadin, naively. So the patient always has to have heparin on board before warfarin can be initiated, and we'll show you that process and why that is so later in this presentation. And of course, heparins typically are given IV. Also can be given subcutaneously